Hello, I'm Dr. Park Jung-chul from Hyo Dental Clinic. Today, I'd like to share a case with you. This case involves extraction of two mandibular molars followed by socket preservation and implant placement. Teeth number 46 and 47 were planned for extraction and subsequent implant placement. On intraoral examination, there was no significant gingival recession. However, because of pain, fracture, and mobility, we decided to extract them. Looking again at the panoramic radiograph, when two molars are extracted, natural healing can result in different healing patterns. Mandibular first molars usually have separated roots with interradicular septal bone, allowing the socket to fill more predictably. In contrast, second molars often have roots that are closer together, creating a larger extraction socket. After extraction, the socket remains larger and may not fill as predictably. When placing a single implant, this may not be a major concern if the bone defect is not that large. However, when both number 46 and 47 are extracted and two implants are planned, the bone levels may heal differently. The number 47 site may heal with a lower bone level, while the number 46 site may demonstrate greater bone fill. As a result, the implants may be placed at different depths, making it difficult to establish matching vertical positions. For this reason, we decided to perform socket preservation before implant placement. This is the intraoral view, and this is the post-extraction view. As you can see, some septal bone remains in the number 46 site. The number 46 site is expected to heal with good bone fill. In contrast, there is no septal bone in the number 47 site. The socket is essentially hollow. With natural healing, a difference in bone levels may develop between the number 46 and 47 sites. For this reason, socket preservation could have been performed only at the number 47 site. However, since both teeth were being extracted, I decided to perform it at both sites. At the number 47 site, I used LCR synthetic bone graft to promote new bone formation. LCR is a low-crystalline hydroxyapatite material marketed by Osstem. Although I hesitate to make a definitive comparison, LCR seems to show a regenerative healing pattern similar to that of allograft materials. Therefore, I first filled the socket with LCR. I then applied AOS collagen over the socket opening. In cases with large defects or significant wall collapse, I strongly recommend using a membrane. In this case, however, my goal was simply to promote secondary healing at the socket opening and achieve faster socket closure, so I used AOS collagen for this purpose. Because AOS collagen contains collagen, I thought it could also support soft tissue healing and help close the socket opening. When graft material is placed in the socket, X-type sutures are often used to prevent the graft material from being displaced. The three most commonly used techniques are the figure-8 suture, crisscross suture, and hidden X suture. Although all three are X-type sutures, their force vectors differ. The figure-8 suture tends to narrow the socket, facilitating socket closure. The crisscross suture exerts pressure from above, whereas the hidden X suture exerts pressure from below. In this case, I used a crisscross suture. However, after observing the healing process, I felt that a hidden X suture might have been a better option. This is the post-operative panoramic radiograph. You can see good bone fill in the sockets. Now let's review the surgical video.
끝. 저기 눌러 꺼져. 됐어. 응? 1%로.
잘 치웠는데.
수술하고 나서 이제 이건
This is the appearance at suture removal 2 weeks after surgery. Some of the AOS collagen can be seen exposed. Looking back, I feel that the hidden X suture may have provided better stabilization. Nevertheless, I had anticipated secondary healing and planned the treatment accordingly. This is the appearance 4 months after surgery. The sites healed very well. This panoramic radiograph was taken before implant placement. Although healing was not yet complete, the vertical bone levels at the number 46 and 47 sites remained relatively flat, as we had hoped.
수술할 때 이제
In cases like this, flapless surgery with a guide would be ideal. I originally scheduled the patient for guide fabrication, but the patient asked whether surgery could be performed that day. So I decided to proceed immediately.
하기로 결정을 했습니다.
After flap elevation, the extraction sites had healed well. The bone had regenerated favorably, and the soft tissue had become considerably thicker. When socket preservation is performed using a resorbable membrane or a material such as AOS collagen for open healing, soft tissue volume tends to be well preserved. In this case, the soft tissue volume remained quite thick, and the hard tissue was also well maintained, with the bone level remaining relatively flat, just as intended. 2 implants were placed. When ISQ values were measured, the number 46 site showed a slightly higher value, likely because septal bone had been present. The number 47 site showed a slightly lower ISQ value. A 6.0 mm diameter healing abutment was connected to the number 46 implant, while a 2.0 mm diameter healing abutment was connected to the number 47 implant. The reason for this is that connecting 2 identical 6.0 mm healing abutments makes suturing between them difficult. By using a smaller healing abutment, the interproximal soft tissue tends to heal almost as if primary closure had been achieved. As you can see at suture removal, the soft tissue healed very cleanly. This approach allows good preservation of keratinized tissue without the need for additional techniques, and healing tends to be more favorable. However, the smaller healing abutment does need to be replaced later under local anesthesia. This is the postoperative panoramic radiograph. In my opinion, adjacent implants should be placed at similar vertical levels whenever possible. When the bone heals well, as in this case, establishing those levels becomes much easier. Approximately 3 months after implant placement, the final prosthesis was delivered. At the final prosthetic stage, the ISQ values were 86 at the number 46 site and 82 at the number 47 site. The bone healed well, and osseointegration appeared to be successful. From the lateral view, the buccal soft tissue volume was also well maintained. The mucogingival junction was also well preserved and remained comparable to that of the adjacent teeth. One of the advantages of socket preservation is the preservation of soft tissue volume. This is the panoramic radiograph after treatment. The vertical levels of the 2 implants are well aligned, and the bone levels have also been maintained. This is the CT image of the number 46 site. The buccolingual bone width has been well preserved. The same can be seen at the number 47 site. There are no strict textbook guidelines regarding indications for socket preservation. However, in a paper published by Darby in 2008, extraction of multiple teeth was suggested as one possible indication. Although this case did not present a severe bone defect, performing socket preservation at the time of extraction helped create a more favorable environment for implant placement and made implant placement easier and more predictable.
그래도 이렇게 발차 보존술을 발차할 때 좀 해주면 임플란트 식립을 할 때 조금 더 쉽고 편안하게 임플란트 수술을
This concludes today's presentation.
만들어주는 게 좀 더 도움이 되었던 것 같습니다.
I look forward to sharing another case with you in the future. Thank you for watching.